Bismillahirrahmanirrahim. Today I'm going to talk about weaning patients from mechanical ventilations, or in another way they say it, liberation of patients from the ventilator. I think this is a big issue. When you start putting the patient on the ventilator, you have to plan from the point of start of ventilating the patient. You have to plan for the weaning. You have to plan for the liberation of the patient from the ventilator. For ventilation is a bridge. It is a bridge. It is not meant to stuck to the patients. What are the stages before? I think it's better to discuss this classification. I have classified this is the stages of ventilation into 4 stages. The first stage is that you start putting the patient on the ventilator. This is the start stage. And this the second part is to stabilize the patient on the ventilator. The third stage is the management stage for the underlying pathology and preparing the patient for the liberation from the mechanical ventilation. And the last stage is the weaning stage. I think this is to make our job a little bit more clear and defined. What's meant by start stage? Start stage, this is you took the decision to put the patient on the ventilator on the assumption that there are certain criteria for ventilating the patient. So you have 2 things to do. The first thing is to prepare the patient by intubation. And this intubation may be through nasotracheal tube or awake intubations or orotracheal intubation with sedations or orotracheal intubations of patients with sedations, neuromuscular blockage. So this is the job. I'm not going to discuss it, but this is you should intubate the patient, preparing the patient for you are going to ventilate the patient invasively. So this is the first one, to prepare the patient. The second part is to prepare the ventilator. So you'll give an order to the technician or to the therapist to prepare the to prepare the ventilator. How to prepare the ventilator? So this is needs that the patient himself. This patient, you have to sometimes you know the provisional the diagnosis. Sometimes you do not know. So you will start preparing the ventilator empirically, and in this case you will give an order for the control variable and phase variable, and what type of ventilator is it, volume or pressure controlled ventilation. So this is a very important part. We usually go through the pressure controlled ventilations, not volume controlled ventilations. And in this case you are given order for the control variable, so the tidal volume usually around 5 to 6 ml per kilogram body weight from the idle body weight. Don't give a high tidal volume, otherwise you will expose yourself to a volley trauma. Respiratory rate, just put a respiratory rate about 12 or 15, something like that. And after that, the frequency of this volume you will set at 60 liters per minute. For the FiO2, usually it is 100. 100%. This is to start it. And respiratory time, if it is volume, in this case, you will put it, or if it is pressure, you will put it in the form of 1 second. Pmax should never exceed 40 centimeter water. The plateau pressure should keep an eye if you are using the patient, if you are using the volume controlled ventilations, the plateau pressure should not exceed 30 to 35 centimeter water. The triggering is 3 to 5 centimeter water. The basal flow, if it is allowable to put it, should be about 10, 15, 20 liter per minute. This is this is the data. So I'm going to tell you how to put it, but this is the data you should fulfill it. Should put it empirically, and empirically with the lung protective strategies. I mean that you take care. This is a patient might be COPD, bronchial asthma, or ARDS, or normal lung. So this in this case, to cut it short, not to harm the patients, go with the tidal volume, lower tidal volume, not higher tidal volume. Respiratory rate is low, not high, to guard against the dynamic hyperinflations. And within 20 to 30 minutes after ventilation, you of the patients, you can take ABG and take your data. This is the first one to take to start. Look at this. This is a volume control. So the volume control, you have to set the tidal volume. The tidal volume Berkeley have mentioned 5, 6 ml per kilogram body weight in order to guard against the volutroma. This is the IE ratio 1 to 2, or the inspirator, or to put the inspirator time, or either to put the flow 60 liter per minute, something like that. You have to adjust. This is the respiratory rate about 15. This is inspiratory pause. This is a beep, and this is the inspirator's time. All this is should be, you should select all these data for the volume controlled if it is like that. If it is pressure controlled, you have to select also the FI2 will be 100%. This is the inspirator time, and this is the ceiling pressure for the patients. Ceiling pressure you set 20, 25, something like that, according to the state of the patients. And this is inspirator time is 1 second, and respiratory rate about 15. This is empirical data to start for the start stage. Then we shift to the stabilization stage. Stabilization stage, this is you put the patient empirically, and you have to adjust. Adjust for what? You put the patient for adjustment. Usually adjustment of the we reach with the data. The main function of the respiratory system is homeostasis of carbon dioxide, oxygen, and pH. So if there's some sort of failure, this means that there's a failure of respiratory system to keep the integrity or to maintain the homeostasis of either oxygen, carbon dioxide, or pH. In this case, that's why the stabilization stage, I am going to handle the data of the patient to adjust this. Just what? Oxygen. This is number one. I put the patient first on 100% oxygen, and after that, after 20 minutes, which is the ranging time, the stabilization state, I should take the ABG and see how much, and accordingly adjust. This is another story. So this is what come down, and the target point is to be with 100 of oxygen with the FiO2 less than 60, which is the toxic level. In this case, I should come down slowly from 100 to 90, 80, something like that. And the accepted one is that the saturation should be around more than 90 with the least FiO2. If there's some sort of problems for the oxygenations, I have to think for the improved oxygenation through recruitment, PEEP, positions, multiple sites, or investigation. This is another story. Carbon dioxide. So I have to adjust carbon dioxide. Carbon dioxide usually it is adjusted close to the normal 35 to 40 millimeter mercury. But in cases of COPD, something else. The target point of COPD is to adjust the pH, not to adjust the carbon dioxide. How to adjust it? I put certain data on the ventilator. This is an empirical data. Empirical data of what? I put tidal volume, I put respiratory rate, and this is by this formula I can adjust the data of the ventilator to the target point of the required carbon dioxide. This is the formula. Partial pressure of carbon dioxide equal carbon dioxide output multiplied by the barometric pressure over tidal volume minus this space multiplied by the respiratory rate. If you want to adjust it, this is we have the measured carbon dioxide after 20 minutes. We talk at this is the carbon dioxide partial pressure of carbon dioxide, actual partial pressure of carbon dioxide. This is the tidal volume, all of it. Tidal volume is this all the tidal volume. This is the tidal volume on the ventilator, and this is the respiratory rate on the ventilator. So I want to adjust this carbon dioxide. This carbon dioxide might be 50. I want to come back with 40. Or this carbon dioxide by these values, it has been washed. It is 25. I want to go 35. So this is the target point or the required. So how much to change either the tidal volume or change the respiratory rate, one of them, and so you can easily adjust the carbon dioxide. So this is a change in the carbon dioxide. This is another formula. You take care. Change in the carbon dioxide will make change in the pH point. This is 10 millimeter mercury change will affect the pH by 0.08 up or down. With the start stage, you set empirical tidal volume, respiratory rate, and after 20 minutes you get the corresponding ABG data. And I have mentioned how to correct this carbon dioxide. Regarding the COPD, as I've mentioned before, the COPD is not the target point is the pH, not the carbon dioxide, because the patient is having already high carbon dioxide, high bicarbonate, and normal, close to normal pH. Acute on top of chronic, this is more acute, more retention of carbon dioxide, and this is associated with drop of the pH. So I have to go back with the pH. How to form this? This is I think I have discussed it. This no in another lectures. This is not for now. Stabilization of the pH, all the same thing. This is we mentioned stabilization of the target point is to stabilize oxygen, stabilize carbon dioxide, stabilize pH. pH, this is another story for the pH. Here we adjust the pH through the adjustment of the carbon dioxide, either wash out carbon dioxide or to retain carbon dioxide. Sometimes that's why this is the target. This is, I think this is the same formula as I've mentioned before. This is the measured carbon dioxide tidal volume respiratory rate, and this is required carbon dioxide tidal volume respiratory rate, and the pH change. This is a 10 millimeter mercury will make change in 0.08. That's why the deviation of the pH, so you can say how much carbon dioxide to be added or to be removed and fulfill this formula. It's very important to handle like that. The management stage after the stabilization and adjustment, I have to take a brush and then do my investigations and see what are the problem for these patients and what are the cause for respiratory failure. So we have to treat the cause of respiratory failure. This bronchospasm, pneumonia, this is shouts of pulmonary embolizations, or neuromuscular problem, thoracic cage derangement in the flat chest, something like that. You have to look for the neuromuscular problems or bronchopulmonary problems as we are going to discuss it later. Improving the extrapulmonary factors to avoid the ventilator complications, improving the respiratory system parameters like resistance, compliance, and the oxygenation alveolar gradient. Adjustment of the ventilator data to be close to the normal. This is the stage. I'm trying to adjust it to be close to the normal alpha data, take the chance of liberating the patient from the ventilator. And you should take care when the patient at night, if the patient is asleep, so there's a decrease in the basal metabolic rate and the carbon dioxide decrease, and so adjustment of the ventilator data in order not to let the patient go in washout carbon dioxide, retention and washout carbon dioxide and retention. This is will make it trouble for the patients, and the patient will not. It will be difficult for him to wean off. The weaning stage, I think this is the topic of now. This is the how to wean. This is the final stage. To wean the patient, I think this is to liberate the patient from the ventilator, to restore the patient normal depending on his respiratory system. This is discontinuation of mechanical ventilation. So the transition process from the total ventilator support to spontaneous breathing. Thank you.